Well, thanks very much, Scott, and also Karen, for asking me to come here. I'd really appreciate being asked, and it's a great honour to speak to you all this year. Interestingly, when Karen said to me, could you talk to us about duplex ultrasound, I thought, oh, that's quite interesting, because in my own mind, I very much view your profession as being a sort of primarily, orthomechanical type business. And then occasionally other things like neurologic conditions and vascular conditions kind of drift into your purview. So although I've given sort of like lots of pod talks on, various things, so this is quite interesting. But so what I wanted to do, rather than just a talk on, vascular ultrasound, something that might be kind of a little bit, try and keep it as relevant as possible in a sort of podiatric type sphere as well. So on that note, as Scott had said, I was just going to sort of have a little overview. So in general talk, I just thought I'd start off with the uses that we use for ultrasound in podiatry, a quick little, not too much on technique, some basic principles and artefacts, reporting, some sort of differential diagnosis, and then also, referral process from your guys' business. Obviously, there's so many things I was just chatting before the talk about the intricacies of PODS referral processes. There's so many weird and wonderful things about what can and can't be done, which is a whole topic for another day, I'm sure. But be that as it may, onwards and upwards. So, in terms of uses from a, podiatric perspective, I think the most obvious one would be people have like clinical peripheral vascular disease. So you get like oldies who come in, they clinically have some problems. They presented to you with a foot problem, but they've obviously got clinical peripheral vascular disease. And obviously you want to take off from there and take it from there. The other thing that I would say is exercise-induced calf pain. And that's going to be sort of a younger population, and often not so much atheromatous disease as some of the other weird and wonderful things that we get to see. And then the other thing I would say is like atypical calf pain. So you guys see so much calf pain, you see so much Achilles disease, but someone who's not responded or not progressing as much as you might, I must say, like, that's to me, not just vascular, but I think that's also quite a good neurologic type red flag too. So people who, we say that all the time, don't we, in like, plantar fasciopathy, someone who's not really progressing, are they really presenting as a sort of Baxter neuropathy rather than as a primary plantar fasciopathy? And I think it's the same in calf. If it's something kind of weird, well, could they actually have a vascular problem rather than just a primarily mechanical problem? So they're the sort of things you should be thinking of. Don't get me wrong, like I don't want to, you don't want to throw the baby out with the bathwater. Most people who have what you think they've got have in fact got what you think they've got. This is just really, I'm just putting sort of flavour to sort of people who don't quite progress as you think they ought to progress. I'm sure you've all had those guys. So, in terms of technique, the fundamental difference between duplex that we use and just the little Doppler guys that you guys all have, or I suppose most of you guys have in your practices, is that in order to get really good duplex studies, you've actually got to get quite a good grayscale image. So if you've got a rubbish image of the calf, you're going to get rubbish Doppler. So whereas M-mode Doppler, which is just the little Doppler probes that you listen and you hear the pulse waves from, it's kind of pretty independent of the quality of the sound waves, and you don't have to necessarily be completely, you know yourself, if you're more on the vessel and you're more perpendicular to the vessel, you'll get a better result. But it's the little Doppler probes are quite forgiving in where you are and where you're pointing and all that sort of stuff. But with a duplex, you've got to be a lot more careful, because in actual fact, and I'll show you images later on, we put a little cursor over the vessel, and if your image of the vessel is not very accurate, then you won't be able to put your cursor on very accurately, and therefore you won't get a reasonable output. And then the other thing is, I don't want to, I was not wanting this to be, particularly on a Sunday morning, I was not wanting to be a physics discussion, so I haven't even put any physics slides in at all. But for those of you that are interested, you realise is that obviously Doppler relates to the frequency shift related to the red cells which are moving towards the probe are going to have a different frequency to the red cells that are moving away from the probe. That's why ambulances sound high, or trains sound high pitch coming towards you, then when they sound away from you. Why, astronomers use redshift to decide exactly how fast things are moving in the galaxy. However, if you've got a vessel like my hand and the red cell's going like so, the more you are perpendicular to it, the greater the inaccuracies. So ideally, what you'd like to do is to be facing exactly down the pipe. So if you're looking straight at the train coming towards you, you get the best Doppler shift. Whereas if you're at the side of the train going past you, you don't get quite the same Doppler shift. So we try, and what I'm trying to say is, we try never to be more than an angle of 60 degrees away from the angle of the flow, otherwise the accuracy is quite low. And that's all I'm going to say about physics, unless someone wants to ask me a question at the end of it. By the way, I've told to have questions and answers at the end, so please ask me anything you want at the end on this or any other topic. I'm very happy to discuss that. I don't know. I've given a million. I diverge a little bit, but I have given a million talks over the years, and always I say, if you've got something to say, stick your hand up and make a comment, and no one ever does. But honestly, if you do have a gripe, just stick your hand up, and I'm very happy to take it on board. So then the other thing I was going to say is that last topic the last line on the slide that I would have shown you already was systematic assessment. In the legs, stenosis can be quite focal, can be, like less than 5 millimetres long. And if you just sort of run down the leg, it's quite easy to completely miss a high-grade stenosis. And I think sometimes when, there's false negatives in Doppler ultrasound, it's just maybe people have been a little bit too rapid in their assessment. And because there's so much collateralization in the legs, one focal stenosis in, say, your superficial femoral artery or posterior tibial artery may have no significance at all, because there's so much collateral flow. But you could easily just walk past it and miss it. Whereas, for example, when you do other things like in the carotids and things like that, it's kind of harder to walk past a pretty high-grade stenosis. They tend to be much more irregular and plaque-like, whereas you do get sort of web-like stenoses in the leg. So that's what I'd say, is that it would be, when we talk about, I'm not even talking about veins today, but at least I was assuming that I was not meant to be talking about veins today, but I'm more than happy to have a discussion about veins today. Clots in the veins, they don't tend to be like short and 5 millimetres. If you've got a clot, if you've got a deep venous thrombus, it's going to be over, at least 4 or 5 centimetres. So no one's going to kind of miss that just by scouring up and down legs. So venous assessment of calves for DVT, or venous assessment of venous insufficiency, is a lot easier in some respects than looking for arterial disease. Be that as it may. We kind of break the arteries up into sort of 3 kind of groups. And from a podiatric point of view, generally speaking, a lot of the stuff's going to be, in the crural, the trifurcation vessels in the calf, because if you have aortoiliac or if you have aortoiliac disease, you're going to present with thigh pain. If you have femoropopliteal disease, you're probably going to present with calf pain. And then if you have like crural disease, you'll often present with, it's extremely rare for people to present with exercise-induced foot pain. People normally present with, bad healing of wounds or night pain or some other things. And that's often, I'll come to that later on, but often vascular comorbidities, diabetics and things like that, will also sort of complicate the issue there as well. So, on that note, again, I don't want to go too complex, but the whole principle about arterial Doppler is that we can accurately measure the velocity of blood in a blood vessel. Now, flow is related to the cross-sectional area of the blood vessel times the velocity. So that's how much blood flow is going through there. So whilst we may not be able to accurately measure the cross-sectional area, if you can show that there's an acceleration of velocity, there is a proportional, you can assume there is a proportional reduction in the area. And that's basically the whole principle about Doppler arterial studies. Now, there's a couple of asterisks there. Firstly, most people quote diameter stenoses, not area stenoses. But in actual fact, Doppler measures a cross-sectional area stenosis, but people think about a greater than 70% diameter stenosis as being relevant. So just bear that in mind, that because we've traditionally looked for arterial problems with angiography, where you measure the diameter on a picture of the arteries, we've used that. But in actual fact, Doppler is actually measuring area stenosis, not diameter stenosis. So just bear that in mind. And the other thing is that the accuracy is not that high. So the reason I've put the asterisks there is that that principle of flow equaling area times velocity is largely correct for laminar flow in a straight vessel with no side branches. However, with a bit of atheroma, there's turbulence, there's acceleration, there's side branches. And the other thing is that flow does not actually equal area times velocity. Flow equals area times velocity, and then about 5 other terms which relate to acceleration and turbulence and all that stuff, which are small in comparison to what I've put up on the board normally, but the moment that those things become complicated, all the other things that are ignored in the thing I've put on the board for you become relatively higher, so they can't be ignored. So again, another point I wanted you to bear in mind is that just be careful when people say there's a 55% stenosis or 63% stenosis. I just don't think Doppler's that accurate, to tell you the truth, and I'll come to how I reckon they should be reported in a second. So generally speaking, we get these sort of waveforms, this image I've just taken from the net, but basically we call this a triphasic waveform. So initially there's forward flow, then there's reverse flow, then in late diastole you get further forward flow. And as you lose that third phase, you can get like diphasic flow, and then, which can be not too bad, and then you can get monophasic flow, which is just up and down, and we often see that in damp situations further down the leg. So that's probably less relevant. I think people get a bit too carried away about waveforms compared to just, is there a stenosis or not? And I think you can be too strung out about things that are of less relevance. So, I mean, how would I report an arterial study? Would be basically normal, plaque but no obstructive disease, a significant stenosis, which as we say is more than a 70% diameter lesion, and to put in some sort of connotation, in broad terms, if you've got a flow acceleration of 2-fold, that's about a 50% stenosis, and 3-fold, it's about a 70% stenosis. So, if the blood is flowing at 50 centimetres a second in the proximal superficial femoral artery, and then we find a jet at 100 centimetres a second, there's probably a 50% stenosis there. Again, these things are only accurate to a point. And then there's occlusion. And then the other thing that you guys want to know is, are all the 3 major vessels patent at the ankle? So the bottom line is, it's less important about whether there's a 30% or a 40% or a 60% stenosis. Basically, normally you're going to do nothing. Plaque and no stenosis, you're not going to do anything about the stenosis. Probably, think about risk factors and things like that. Obviously, you probably don't get quite as involved about that. But to tell you the truth, what's been shown in smoking is that every intervention helps. And every person that intervenes with someone who says, stop smoking is itself a benefit, if you know what I mean. So every health intervention is valuable. So, I mean, if you guys say, just watch your smoking, watch your diet, is your blood pressure under control and things like that, people are much more likely to adhere to therapies the more reinforcement they get. Again, I just as a side little issue, I'll just diverge for another thing, but wearing another hat at Envision, we do a lot of, cardiology and a lot of cardiovascular type studies, and you may or may not be aware, but like statins, for example, which are obviously treated to lower lipids, we basically are giving statins to probably 19 out of 20 people to save the 1 in 20. So in actual fact, there's probably a benefit for 5% of the people who take statins will actually get a benefit. But the trouble is we don't know who the 5% are. And that was, a few years ago, there was a quantum show on ABC saying, we shouldn't be taking statins because 19 out of 20 people aren't getting any benefit at all. But the trouble is that you don't know the 5% who are getting the benefit. And if you're the person, the 1 in 20 who has a stroke because you weren't on statins, well, that doesn't help. Interestingly, now we have a lot of non-invasive ways of looking for arterial disease. So, for example, in the heart, we do a lot of coronary CT angiography. And so, in some respects, if you've got like a stenosis or you've got a lot of plaque in your heart and you've got high lipids, that's obviously much more important to you, because now increasingly we're showing that if you've got completely pristine vessels and high lipids, you may not get a great benefit about treating your elevated lipids if you've got pristine vessels, because your parents were really good to you and had no arterial disease themselves. And conversely, if your lipids aren't very high but you've got bad parents and who had horrible vascular disease, you're probably much more likely to want to be getting onto that. But where I'm coming with this point is there's now quite a lot of evidence now that when doctors put patients onto statins, probably about 50% of them are probably not taking them 6 months after they've been put on them. So when someone says you've got to take this pill for the rest of your life, which may or may not benefit you in 45 years, a lot of people just stop taking them. But what we do know is when people come to us and they have like a non-invasive image of their arteries and see that they've got a lot of plaque or some little, 40% stenoses, there's now quite a lot of surveys now to show that people who actually have a visualised proof that they have atherosclerotic disease are much more likely to comply and keep on taking the statins. So the point I'm coming around in a very circular way to saying is that all these things that, you think you guys might have no benefit, but, every time that someone comes to you with vascular disease and, they're like a smoker and their, lipids are out of control and their hypertension out of control, like every little intervention that says, look, if you actually change your risk factors, you could dramatically change your life. Every little intervention like that increases the chance that people will actually adhere to the therapy. Yeah. Did you say cabbage, did you say? Yeah. So for those who couldn't hear, the question was too, like there is a sort of muscle pain comorbidity with statins, which we're all aware of. And then the second thing was how does cabbage interfere with lower limb perfusion, let's say. Start with one. What we know is that in actual fact, muscle damage, muscle pain is not uncommon with statins, but what we do know is that if your GPs start your guys on low levels, so even if people want to have got high lipids and they're high risk, what we do know is if people start on a high dose straight away, a high proportion of them will get muscle pain and stop taking it. And what we do know is that even if you want to get to a high dose level, what we know is even if you start low dose with a view that I'm never actually going to get to my real dose for another 6 months or longer, we're talking about 20 years, we know that that causes less damage, less muscle pain, and people are much more likely to comply. So that's what we've learned is we used to, even if we thought people should be on high dose statins, we've now learned under no circumstances start them off on high dose statins. A bit like beta blockers and things like that. If you start them high, people get tired and they resent them and then they won't take them. Nothing about cabbage. I mean, obviously, you don't just get peripheral vascular disease, do you? Vascular disease is a general systemic problem. You have strokes, you have renal disease, you have heart disease, and you have peripheral vascular disease. And exactly what proportion you have of one or the other is not 100%. But yeah, no doubt at all. If you've got a poor cardiac function, then you're going to have poor perfusion, if you've got perfect arteries in your legs. And so cabbage, in view of making if it improves your left ventricular function, quite apart from helping you to not die of a heart attack, will also tend to improve peripheral vascular disease. So, and that happens, and also it will also help your renal perfusion, which will then also help your general health as well, and things like that, and also diminish the chances that you then have cerebrovascular disease and a stroke as well. So there's no doubt all these things, like reperfusion by whatever method of the heart, will probably help your legs as well.
Excuse me.
Yeah.
When they take the statins, where do they get the pain? In all over their body, or?
Classically thigh pain, not always, but classically thigh pain. And I don't know why people get thigh pain, because I don't know whether you guys see a lot of people, like cementless hip arthroplasties can often get thigh pain. Have people come to you guys with that thing where the uncemented femoral components, they sometimes get a bit of a thigh pain from that as well, with the bone ingrowth into the prosthesis. So, it's weird, some of this thigh pain. And you get me going, like I could talk about thigh pain to you guys for a whole day as well too. There's a whole lot of thighs, things like myositis syndrome, so polymyositis, dermatomyositis, it often goes to thighs first. Steroid myopathy tends to go to the thighs first. Why the thighs? I don't know. I don't know whether maybe that's your thighs are probably your most active muscles of any part of your body, but I'm speaking off the top of my head now, not with evidence basis. But off the top of my head, I'm thinking that's the only thing is that, when you're running, probably that's the largest muscle bulk, and maybe that's the thing that gets affected the most. But a lot of things happen in your thighs. So, referral. So in terms of arterial studies, and for that matter for, DVT studies as well, to tell you the truth, so any Doppler study, not just arterial studies, but also venous studies, as a group of podiatrists, you can absolutely refer, but there's no unfortunate rebate from podiatrists from the MBS for your patients if you refer for a Doppler study, as distinct from when a GP does. But in some respects, most of the guys, at least most of the older people in the room, would know that for a long time, like at Envision, for example, we've been doing MR for podiatrists for forever. And it's the same sort of situation that, no problems about referring, but just your patients don't get anything back from Medicare if you guys refer as compared to an orthopaedic surgeon refers. But sometimes, by the time you've gone through 3 stages and you've seen 3 other people, by the time you've sent people back to a GP to get a referral, to get the study that they want, they're actually probably not necessarily that much better out of pocket, and certainly a lot of time out of pocket than if you had just ordered it yourself and they got nothing back, if you know what I mean. So just be aware of that, anything, the Radiation Council, that's what I was saying before the meeting, the Radiation Council of WA determines what podiatrists in Western Australia can legally refer to, and it's largely ionising radiation. So obviously you can refer for any x-rays around the foot or anything like that, but you can't in Western Australia refer for a hip x-ray, whereas in New South Wales and Queensland you can. And similarly, the whole lot of things are the podiatric surgeons, have issues with screening in theatre and things like that. But a lot of that is to do with the Radiation Council of Western Australia. And so anything that doesn't use ionising radiation, such as MR or ultrasound, of which, to the best of our knowledge, there is zero risk to the patient, those things are not controlled by the Radiation Council. The PBS, if you like, federal government decides what people might get something back for, or not, as the case may be. So just bear in your own mind, it's a bit complex, but particularly with ionising radiation, it's the Radiation Council of Western Australia that determines what podiatrists can and can't refer for. The PBS has a whole lot of other things that you can and can't refer for, and it's not necessarily the same thing, which I find bizarre, because it should be. But in general terms, often what happens is a bit like other things or like things like injections, it's the same thing, we can do injections for you, but not so much the pods, but I don't know whether you know some of your paraclinical colleagues. So for example, I think pods have done really quite well that when you guys send for an x-ray of the feet or injections of the feet or ultrasound of the feet, your guys get pretty much the same as they do from a GP. But so for example, the physios don't get anything from anything, really. They can get a rebate for x-rays, but not for feet or shoulders or anything like that. So I think in some respects, at least you guys have done quite well that at least things around the feet can be rebated for your patients, commensurate with GP levels. So, who should you refer? I think, the classic thing would be clinical things like, let's be frank, I know there's a few new grads floating around here, and I hope the old grads here can tell the new grads that one thing I have seen, so I'm approaching my 6th circle birthday, so I've been in the business for a little while. but I have seen a noticeable shift in the whole of medicine and paraclinical disciplines away from just trusting your gut feel to increasing reliance on investigations. And of course that's been to, my practices and pathology practices' benefit, but I don't necessarily think that's been always to patients' benefit, and certainly not to the wearing your taxpayer of Australia's benefit, is that it's not just a medico-legal thing. There's been kind of a more reliance that we can trust the investigations more than we can trust our clinical feeling. And if I could say just one thing to the new grads here, what you actually think is going on is very frequently what's going on. It may not be 100% of the case, but 95% of the time what you clinically think is going on is in fact going on. And to increase that 95% level of, accuracy to 100% of accuracy, it is an absolute, diminishing return. So to increase your level of confidence from 95% to 98% costs a hell of a lot in pathology and imaging and other specialised studies. And we pay a fortune to just get in this country, to get a small increment in what people think. And I've often thought if people just trust their gut, if you're wrong, it will turn up, like you won't win, and then, you can reassess that in, a month or 2 months, and you were wrong. But very commonly, that would be just my thing, which sounds a bit unusual coming from a radiologist, but of all the people I've seen, I'd say just sometimes kind of trust yourself because it's not that bad. But that being said, if you think people have got bad vascularity, they often do. But then I don't know whether you've got the little handheld Dopplers and you can't detect their Dopplers, you can't get a dorsalis pedis or something like that, and you think, or they've got, like the skin looks a bit thin and it looks a bit weary, or they've had like an ulcer lurking there for a while. You've seen them all, obviously. The sort of people that you get very, very nervous about doing anything on their feet because you think this could go pear-shaped, and they're diabetic as well, and you think, oh, this looks a bit not for me to be gouging around in. The other thing I was going to say is exercise-induced pain, and then what I was saying to you before, if people have vascular comorbidity, so if you know someone comes to you with diabetes or significant renal impairment, you know that they're going to have small vessel disease before they get there. And obviously smokers, and thank God that our smoking's actually come down, because now smoking rates have come down so much in this country, so that, usually they're down to about 14%, which is, I think fantastic compared to most other, Western democracies even. You realise, of course, in Asia it's going completely out of control because the tobacco companies just shifted from, a diminishing market to an increasing market. And again, you'll get me going because, I have my secret suspicion that given that all the tobacco companies own all the vaping companies, I have my suspicion that it's just, like we're not giving up yet on, like they've given up cigarettes, but we'll get back to them eventually. But be that as it may, thankfully, there's not that many smokers. So in the causes tend to be like peripheral vascular disease or artery compression syndromes. They would be the two big things that you want to see. There's another, if you like, vascular problem compartment syndrome, but I've just put that in yellow in brackets because that doesn't really affect us. That's something that you assess with, usually the sports medicine guys do that by direct measurements of, compartment pressures. And that's nothing that, like usually most radiological tests will be completely normal in people with compartment syndromes. And again, that's a bit of a clinical, that's a pretty good clinical diagnosis. You can confirm it with pressure measurements, but you're not going to be sticking needles into people's calves willy-nilly. A bit like, I deal with a lot of the guys who deal with like tarsal tunnel, and the real problem for you guys is that feet hurt a little bit more with needles than other things do. So things like electrophysiological studies, so for example, in carpal tunnel, almost everyone who has carpal tunnel will have an electrophysiological studies to confirm the diagnosis, but when you start sticking needles to do electrophysiological studies into intrinsic muscles in the foot and things like that, it's not, I'm sure you've had people come back with EMGs and not saying, well, that wasn't the most nicest, investigation I ever had in my life, I think it'd be fair to say. But be that as it may, compartment syndrome, you're not going to do that on everyone, but I've just put that in brackets because that is, I guess, classically a vascular problem, but we're not involved on a Doppler situation. And then other non-vascular things that masquerade. I thought I'd just put this in as well because just like what you think is orthomechanical may be arterial, there's a lot of arterial things that may be not arterial. And as I said, the sort of things you're going to flag for you are going to be older patients or smokers, people who've got ischemic heart disease. We're talking about cabbages and things like that. strokes, renal dysfunction, poor pulses, vascular disease elsewhere. They're the ones you're going to be worried about, even if you're not that worried about the pulses. So I might have to use the trackpad here a little bit. Failing that. Do we have a laser at all or not? Or no? That's all right. It's okay. Try and get the mouse to pop up a bit. No. Oh, here we go. Fair enough. So this is like an arterial. So this sort of thing we say. I was talking before. So this is the vessel here. We code, flow towards as red and flow away as blue, but you can flip it if you know what I mean. So we kind of make arteries look red and veins look blue because kind of that's what's flowing in the middle of them. But just be aware that's just flow direction, and you can just flip the switch. And you can make an artery blue and you can make a vein red if you want. But by convention, we kind of like to make arteries look red. So you see this big plaque here, and then obviously, because the area at that point is narrowed, the sort of whiteness is the velocity. That's a code for velocity as well. I can show you some numerical things as well. But there's obviously an accelerated jet coming off that stenosis. So then if you interrogate within that accelerated jet, you'll find a flow acceleration, and then from that flow acceleration you can determine how much stenosis there is at that level. Be careful. A lot of people will sort of actually directly measure those measurements, but in ultrasound it's not that accurate. So direct measurements of stenosis are not as accurate as the actual Doppler flow disturbance, if you know what I mean. There's a whole reason for that. You think, well, should be. Why can't you just measure the narrowing? But very frequently it can be quite inaccurate with the actual direct measurements. So what I was trying to say to you is this is a popliteal artery with a stent in it, and you can see sort of like, you guys have seen stents. Have you seen stents in reality? They're like, they're like little meshwork type of thing. They're like a tennis racket, but they're all folded up, so they've got like little gaps and holes and things like that. So in actual fact, you are physically seeing the mesh of the stent there. This is obviously the flow in the artery there, and this is what I was saying, this gate. That we want to then put this gate exactly where we measured. So in that other example I showed you, you'd want to put that gate straight where the rapid flow is. If you didn't have the gate where the rapid flow is, you wouldn't find the high acceleration. So this is sort of like biphasic flow, and we can actually measure, and then we can actually measure the actual maximum flow there with the peak systolic velocity of 40 centimetres a second. And then what we do is, if that popliteal artery stent had got endoluminal regrowth or something like that, we'd see a little focus where the flow would accelerate a little bit. So, in some respects, for people involved with peripheral vascular disease, it's really, really, really important for them. But from a radiological point of view, there are lots of things that we do that have a whole range of diagnoses and things like that. But to tell you the truth, peripheral vascular disease for us is normal artery or narrowed artery, if you know what I mean. And I could bang on a hell of a long time about going on about it, but basically is, do you have a narrowing or do you not have a narrowing, basically? So there's not a lot of, and there's a whole lot of other causes, including vasculitis. There's these, you would have heard about, other in congenital development, you get like, Takayasu and Kawasaki, you get all these other sort of congenital conditions you can get. But let's be frank, 99% of people with vascular disease who are 70 years in this country have atheromatous disease. They don't actually have, vasculitis and things like that. So there are a whole lot of weird and wonderful vasculitic causes, but almost all of it's atheroma. And so it's atheroma and it's narrowed or it's not narrow. So unfortunately that for me is not that super, super interesting, very important for the patients, but not that super interesting. By contrast, there's other things like that which are interesting to me, which is what I wanted to show one of these sorts of things. Because I like showing interesting things, basically. So I don't know whether any of you guys have had a popliteal artery entrapment in the room or anything like that, but we see them not that frequently, but not that infrequently. And then iliac artery compression is quite rare, but we see it sort of rarely, I'd say. And interestingly, one of my colleagues, Eamon Coe, who some of you might have dealt with if you've actually referred to us as well, is he's developed quite an interest in the role of botulinum toxin, so Botox, in a whole lot of range of issues. And I won't go into it now, but there are also myofascial compression syndrome. So sometimes people can get like brachial plexopathies from the scalene muscles compressing. And I don't know, some neurologists are using a lot of Botox also for, like tension headaches tends to be cervico-occipital, muscle tension, and people have been using Botox for sort of tension headaches. And he's been using Botox for around the neck. And then I don't know whether you guys, I don't know whether they come to you so much, but people like have piriformis syndrome. He's been using a bit of where the sciatic nerve gets trapped by the piriformis as it emerges from the pelvic notch, and he's been using Botox to treat those guys as well too. So we've been using a lot of Botox. I have said to him, like, the actual bottle that we get, he only ever uses about half a bottle, and I have wondered whether he sort of, takes it home and uses it elsewhere as well, but he denies that and intends it. But we use quite a bit of Botox. But one other thing he's done is that he was talking about this sort of stuff where in this popliteal artery entrapment, if you actually poison the arteries with Botox, you can actually treat the condition without the more traditional surgical options that there have been before of dealing with it. So, you guys, I don't know, like the gastrocnemius soleus complex, the soleus, it starts with there's like an aponeurotic arch which goes from the tibia over the fibula, and there's the deep posterior compartment that has the popliteus muscle, plus also the popliteal arteries, and the actual soleus has an arch, and then the two heads, the gastrocnemius, come off the back of the femoral heads. So going in there surgically is often, you're cutting a few things that may or may not be of use to you later on in your life. So he's done a thing with Botox, is what I'm saying. So to sort of put it in context, so this is someone's popliteal artery. So we're looking at, in the popliteal fossa behind the knee, just looking longitudinally. And this top left-hand image, this is from a paper he wrote that I just showed you there. So that's at rest, and then after the patient does exercise. And you can see how the popliteal artery is almost completely compressed by the overlying gastrocnemius soleus complex, and particularly the medial head of the gastrocnemius. And the other thing you'll see is this is the systolic velocity here, which is 90 centimetres a second, and the peak systolic velocities there is 260. My maths ain't that good, but let's say it about 3 times, if you know what I mean. So there's a significant, that there's a significant stenosis, and there's a lot of flow acceleration, given that the same amount of blood has to go through a vessel that size as through a vessel that size. So if the same amount of blood has to go through the smaller space, it obviously has to go through faster. Yeah. How much did what, sorry?
How long does it stay like that?
Oh, often for quite a long time, and then what happens is they rest and then it comes good over a period of time. But every time they exercise, they can get this calf pain. That's the classic thing, is that, Yeah, once they stop, it just tends to settle down as soon as as soon as they start running, after a while, they then start getting the symptoms too. So the top 2 images are non-exercise and with exercise in the popliteal artery, and then this is after treatment, and this is at rest, and then this is with plantar flexion exercise, and you can see this is still narrower than that, but it's much improved. And if you look, the total maximum velocity hasn't actually changed that much. And to tell you the truth, to have a hemodynamically significant effect, the reason we use 70% stenosis is that you need to actually, bizarre as it may seem, it's not bizarre actually. Let's go into the garden. When you're watering your garden and you want to stop the hose flowing, if you just squish the hose, nothing happens. And you have to kind of bend the hose almost double to make the water stop flowing. And even when you bend it over double, you still get a bit of a flow. It's often when you bend it over double, then put another twist in it that you actually stop the water flowing. So what we know is that you need to actually diminish, we know from flow dynamics, you need to diminish the cross-sectional area of a tube by about 90% to actually have a flow effect. So in your coronary arteries, you've got to have a real tight stenosis before it does anything. Of course, if you've got a 90% stenosis, it doesn't take a lot to have a little bleed into that and then have a 100% occlusion, and then you suddenly have an occlusion. But in terms of stenotic lesion, you really have to have quite a tight stenosis to actually change the blood flow. So by the time people present with claudication from their peripheral vascular disease, they've got quite bad disease, really. It's not like a little bit. But so if you just use my, bending, how much do you have to narrow off a garden hose to make the flow stop? really need to do that. So although you can see here on my images that, I don't know, just off the top of my head, I reckon it's still probably narrowing by about 20 to 30% in exercise, but it doesn't actually have any flow effect, and the person's symptoms had gone. The slight downside, unfortunately, is this is the medial head of gastrocnemius. So this time we're looking cross-sectionally. So, that's the medial popliteal fossa, that's lateral gastrocnemius, medial gastrocnemius. And you can see how that sort of echogenic change is from denervation change. You can see on the corresponding MR, this brightness in the medial gastrocnemius is from where the muscle is poisoned. You can obviously see that's the vein, that's the artery. You can see how they can come quite close to it. So hypertrophied muscles that get really big in exercise can actually narrow the artery down. So that's it, yeah.
So if we had someone who might, a young athlete getting this sort of pain, would we be able to say we've all, a lot of us have got the hang of your gauntlets, would we be able to do listen on the foot and get them to go for a run and immediately do it again, and would we find a reduction?
Potentially, yes. So if you were listening at like dorsalis. Yeah. So totally, if you're listening at like, the tib post at the ankle or the dorsalis pedis or something like that, and you get them to exercise and, they do a little bit of foot flexion, things like that, and you notice that the signal goes away, that would be supportive. They might still have it and you might not be able to detect that, to tell you the truth, but yeah, no, it's certainly something to think about. And the bottom line is, like, 25-year-olds having exercise-induced calf pain, they're not going to have peripheral vascular disease. A lot of the other things they're not going to have, if you know what I mean. So they're much more likely to have a developmental problem than they are to have a sort of acquired atheromatous problem. And on the same ilk, you can get iliac artery compression. So I don't know, you often see this in like bike riders who get like thigh pain or calf pain when they do a lot of bike riding, and that's because the iliac arteries get sort of compressed in the groin, particularly in people who are like, when you're doing exercise. It's a weird thing to do, bike riding, isn't it? Two things I've thought are weird. A, bike riding, you're doing a lot of exercise with your back flexed, and the other thing I've thought is hockey. Seems to me like crazy. Like I've got plenty of people who are hockey. I think it's a great sport, but running around bent over halfway seems to me a real bad thing to do, rather than running around standing up straight. So, but anyway, you can imagine. So I apologise deeply to all you intense hockey player lovers there. I just think it's weird, or you should have longer sticks and run around upright rather than bent over or something like that, But it just seems fundamentally wrong. So what I showed you before, was. So this is the iliac artery, the common iliac artery at rest. And then literally this particular person, we actually got them to bring, they were keen cyclists, and we got them to bring their little, what COVID has done is has created an enormous profit, I think, for bicycling bike manufacturers and all the sort of Zwift machines and all that sort of stuff. I think particularly like in Victoria and things like that, they must be going, hell for leather. But before coronavirus, I think people had the Zwift machines, but maybe not the same proportion of people who have them now. I think it's been real good business for them. Not, I use Zwift in sort of term, but like the things that you hook your bike onto properly. Be that as it may, so she actually brought her machine into the practice. We stuck it up next to the ultrasound machine. She jumped on, rode the, pretend few kilometres, and then jumped back onto the scanner. And so then you can see how the iliac artery narrowed down a lot, which is obviously, I measured it, but that's neither here nor there. You can see that. And the other thing is that not merely, the colour change, that often reflects a bit of turbulence. So it's not merely accelerating, but it's also turbulent flow. And you can see down the bottom there, so that went up to, 500 centimetres a second. Like 100 centimetres a second is a lot in an artery, even in someone fit. So that's hugely accelerated. And this was just from a CT angiography that we did, and doesn't quite show, but in actual fact, we can see narrowing there. It's obviously not, if you compare sides, you can see the left is narrower than the right. obviously at the end of, we often end up doing proper CT angiography to confirm all these diagnoses as well, and maybe I should just blow that one up a little bit more, but that's a couple of vascular compressions. I just wanted to do a couple of non-vascular mimics, because other things cause exercise-induced or even, pain in the calves on exercise. And obviously lumbar radiculopathy would be the classic, rather than vascular claudication, you can obviously get claudication from spinal stenosis or radiculopathy. And, particularly people who have a bit of instability in their spine, they'll often get a bit of So L5 radiculopathy can masquerade as a whole lot of, L5 radiculopathy can masquerade as groin pain, kind of SI joint pain, hamstrings, origin pain, calf pain, foot pain, and things like that. And sometimes this one, but I often see L5 radiculopathy, and you've seen that yourself, we're not winning here. In actual fact, they've got a bad back. The other thing I was going to talk about is Achilles and paratenon pathology, but believe me, not today. We can talk about that another day, and you guys are, the full guts on that in any case. I just want to talk briefly about plantaris invagination. I don't know whether you guys are, we see that a lot in sportsmen, much more than other people. And then something about post-traumatic scarring as other reasons why young people for no other real good cause might have calf pain. So, I don't know whether you guys have seen many of those, but we see this actually surprisingly common in elite sports guys. So the plantaris sort of runs between the soleus and the gastrocnemius, a little muscle high up, but basically a tendon the whole way down, and then it inserts onto the medial aspect of the Achilles tendon. And where it inserts in the medial tendon, you can get a little, if the plantaris is inflamed, you can actually get a little bit of a tendinopathy. So Achilles tendinopathy that's very medial is something that's a bit of a flag for us. Are you really dealing with Achilles tendinopathy, or is this actually like a plantaris invagination situation? And we see this quite a lot in the AFL footballers. I don't know why it is in that level, but it might have to do with workloads and things like that. But that's just something to be aware of. Like, not all Achilles tendinopathies. Achilles tendinopathy can actually be plantaris tendinopathy and invagination issues there. So that's just a little flag for that one. And then another thing that Eamon was involved about is chronic calf strain injuries. So, you guys have seen a million people. People do a medial people run, they do too much, they do a medial head gastrocnemius, partial thickness tear. You guys would know it's almost always it's at the distal myotendinous junction of the medial head of the gastrocnemius, just where it's joining onto the Achilles tendon. It's horrible, they can't walk up steps, 4 to 6 weeks later they're all fine. The only trouble is you must have run into these people who either have recurrent episodes of calf tendon or people who just never seem to get over the calf strain. And what we've learned is that if you don't treat it well, and I think often some people often don't get rehab that well, and they hobble around for 6 weeks. And I think if people hobble around for 6 weeks, they can get the whole sort of gastrocnemius soleus Achilles complex can be a little bit shortened permanently if they don't actually start walking properly after these things. And also, again, if you have it recurrently, you can get these scarring. So this also we see a lot in the footy players that we do, but we also see it elsewhere too. So this is what I'm saying. So this is a pretty typical appearance. So medial gastrocnemius, lateral, soleus here, obviously to orientate yourself, medial side, pretty typical. Myotendinous junctional tear acutely. And most of these guys will do perfectly okay. However, sometimes they don't. And this person then went on, as we see quite frequently, to then develop all scarring about the myotendinous junction and the aponeurosis. And what Eamon has postulated, and a lot of other people are thinking about now, is that the normal functioning of calf requires all the muscles in your posterior compartment to slide over each other normally. The aponeurosis allows the soleus and the gastrocnemius heads to slide over each other, and if they get stuck down to each other, you predispose yourself to tearing the muscles again or to having chronic pain. And so what happens is you get this scarring, and then suddenly the gastrocnemius soleus is one unit, not working independently, and then you predispose yourself to calf strain. So this is scarring of that medial aponeurosis there, and on ultrasound, it sort of just looks like a big, thick, echogenic fat thing, whereas normally it doesn't look like that. I don't know, that's the superficial fascia. That's what it normally looks like when we see it. It shouldn't see this big back echogenic thing like that. And so what Eamon's been doing is he's been doing adhesiolysis, where he's been injecting normal saline into that aponeurotic plane, and as he injects quite a large volume of normal saline, it separates out the scar, and what the arrows here are showing is most of this is normal saline, injected normal saline in that patient, and you can see all these little, they're like fibrous adhesions that are outlined by all the saline circulating around them. And so we've seen people, who have chronic pain, get rid of the chronic pain, but also people who keep on coming back, like, I don't know whether you get those patients, but I see them because I suppose they come to us to look at their calves all the time, but people who get like a medial gastrocnemius tear, and they do it like every 3 months, and they go for years and years and years. Every 3 months they keep on doing a, medial gastrocnemius, whereas most people who do it once don't do it ever again in their lives, kind of thing. So that's just a little bit of something to think about in young people who have chronic or exercise-related calf pain that might not be, in fact, vascular. So that's just a bit of a summary of what I've said, but just to review those things, obviously venous studies are a whole another kettle of fish that I could talk about, venous insufficiencies, DVTs, but you guys will often send them on to the GPs. And then be aware of these other sort of musculoskeletal mimics of arterial disease as well. So thanks very much for your attention, and I'm happy to answer anything as best as I can, and it doesn't have to be arterial or anything.
I haven't really got questions, but I thought that was quite interesting when you were talking about patients needing a visual to help educate them. So I started using just a simple Doppler when I do a neurovascular assessment, and I tell the patient what I'm going to look for, and then once they see the biphasic, then they are eager to see the next one's going to be. And so I'm actually using that as a leading indicator to talk about if they do get all four foot pulses biphasic, I then use that as a lesson on how to keep the blood flow healthy, and talk about anti-smoking and cholesterol management, stuff like that. So I'm actually using that visual to get them engaged to then keep them healthy, as opposed to like looking for disease and stuff like that. So I thought that was quite interesting that you're doing the same thing. And the other thing is, I also think that it's not us clinicians necessarily not trusting ourselves and looking for more investigations. I think the patients, because they're Googling and they aren't necessarily trusting us, and they want to see some proof, and I'm actually one of those. So I say, no, you're fine, and then, but I actually want to have that cardio CT scan.
Yeah.
And then I feel a lot better. So yeah, I think that there's actually a push from the patients as well to get these tests done, and they're prepared to pay.
Yeah, if I can take your second point, I'm sure you're right. In terms of your second thing, in terms of your first thing, there's no doubt that humans do not respond to risk factors that well. Because it's hard to do. I know those of you guys who've had babies and things like that, you do first trimester testing, and you're given like a risk factor. So what does a 1 in 420 risk of Downs mean to you, if you know what I mean? And so a lot of people, as you say, would much prefer to actually have the chromosomal assessment than say, well, you've got a risk factor. And we don't really work on risk factors. We get worried about sharks, but the risk factor of being eaten by a shark is low, if you know what I mean. We don't get worried about driving home today, but the risk of actually dying, any of us in this room dying on the roads on the way home today would be many, many quanta higher than being eaten by a shark at Esperance. But what people are worried about is being eaten by a shark in Esperance, not... But, we all drive our cars, blasé, completely thinking they're the safest thing on houses, yet swimming, even today, even at that beach at Esperance, is still infinitely safer than just driving home tonight. So we don't deal with risk factors and risk suggestion that well.
With your exercise-induced calf pain, why do you think that's particularly a risk factor for young people? Not older athletes, older people?
Oh, no, totally as well, too. What I'd say is, though, in older people, you'd be more worried about, conventional. The older people, you are worried about real peripheral vascular disease, as distinct from these other sort of less common but weirder things. So I really just wanted to highlight that in young people, it's less likely they're going to be peripheral vascular disease. But yeah, sure, like a 55-year-old person who's got a history of heart disease and has the problems, you'd certainly be worried about more conventional disease, for sure, definitely.
The scarring and the aponeurosis that you were talking about, is that visual on MR?
Yeah, but I wouldn't do an MR first up, but yes, it shows up really well on MR. I mean, a lot of things like, sometimes people think that ultrasound is a poor man's MR, but in actual fact, they're quite complementary studies as well too, because you can't do anything dynamic in MR. They're just lying there flat on the table, whereas you can do a whole lot of stuff. And that's why, you know, you think about like tendons around the ankles. Like people say, well, like, you know, ultrasound of the ankle is a poor man's MR of the ankle. Well, there's clearly things like if you're looking at the talocrural articular cartilage and things like that, obviously ultrasound cannot see into the joints and things. There are some things that ultrasound can't do. But things like para-articular tendons, I often actually prefer ultrasound in that situation than MR. And things like, you know, perineal subluxation or instability, you can actually test that in real life. But when someone's just lying flat on their back in the scanner, you know, you don't actually see that nearly as much. There's a whole lot of things in other parts of the body, you know, with dynamic problems that you can do with ultrasound that you can't do with MR. So I view them definitely as tests that help each other rather than necessarily one is better than the other. But there's no doubt there are some things that MR shows better. You know, so MR will show muscle strain better. You know, so if you've got a plantar fasciopathy, and we look, obviously everyone who has plantar fasciopathy, we will look at the adductor digiti minimi to look for denervation change for a neuropathy type thing. And like we see that at ultrasound, but you see it better at MR. And, you know, sometimes you can see, but sometimes, you know, you appreciate tendon tears a little bit better. So in the plantar fascia itself, sometimes that's appreciate, like everything just looks grey and miserable at MR, but you get a better idea sometimes at ultrasound about where there's a tear there or not, and you can poke on it and see whether it moves and things like that. And the other thing that we get at MR, at ultrasound we don't get at MR is, you know, because of Doppler, I mean, I was asked to talk about Doppler as a Doppler test, but we obviously use Doppler for assessing hyperemia too. So, you know what I mean? So we get all that extra benefit, like how hyperemic is the tendon. So when you've got tenosynovitis is, you know, the middle-aged women with the tib post, you know, the chronically everted feet, tib post tendinopathy, spring ligamentopathy, you know, posterior subtalar arthropathy, that sort of syndrome that you've seen a bazillion times yourself. It's kind of helpful for us to see, what is the spring ligament and the tibial posterior tendon? Are they hyperemic? Or is this like it's a more acute thing? Or is this chronic and they might have been like that for 10 years and they might be presenting with something else? So, you know, the short answer to your question is, yes, you can see the thickening at MR. But yeah, so I mean, off the top of my head, I'm not exactly sure, but a conventional ultrasound would be with us probably about a couple of hundred. They would get probably about 90 or 100 back from Medicare. That's with you guys. A Doppler is more expensive, might be, you know, 300 or something like that, but they get a significant amount more on a rebated study, so it'd be probably about 300 or something like that, so not insignificant sum of money. Obviously MR unrebated is, you know, it varies around town, but it's of the, you know, $300 to $350 around town for an unrebated MR out of pocket. But then, you know, like the MR I think is a bit easier than the Doppler one to argue, because by the time you've gone to an orthopaedic surgeon to get a specialist referral, you could easily cop a $100, you know, bill for just going to the orthopaedic surgeon to get the referral, not to mention the time, opportunity cost of the time and things like that. But yeah, no, obviously it's more expensive, definitely. Oh well. If we're all good, thank you very much for asking me.